You are listening to Armchair Healthcare, a podcast on pills, placebos, and policy.
All right, welcome to Armchair Healthcare. How you doing, Max? What happened this week?
Oh, quite a lot. One of the big stories was that Eli Lilly had some really fantastic data for their dual GLP-1 and GIP agonist.
Okay, cool. Tell me about it.
Yeah, the drug is, instead of oral like semaglutide from Novo Nordisk, this one is subcutaneous once a week.
All right.
But the data is utterly fantastic for anyone with diabetes. Although, just to be fair, this is a phase 2 study. So it has several hundred patients, but it's not like a super duper large phase 3. It's more of a dose finding study. But at the high dose, which was 15 milligrams, the average weight loss was 25 pounds over 6 months.
25 pounds for 6 months? That's huge.
Yes, exactly. And if you look at the curves, because they monitor them across different time points, they were still going down. It wasn't like it kind of plateaued or just stayed at that level. It was like so if they followed them for a year, it might be even more.
All right, so I'm going to ask you questions about all the usual suspects in a weight loss trial. First off, was this placebo adjusted 25 pounds?
No, but so the placebo only lost, I'm trying to look at these really small graphs here, like 0.4 kilos.
0.4 kilos. All right, so this is the outperforming placebo pretty damn well.
Yeah.
Which is one thing that I always think of in these weight loss trials.
Well, it wasn't a weight loss trial, it's a diabetes trial.
A diabetes trial. That's a good point.
Yes, this is a diabetes trial. And
a lot of time people like in these trials will get motivated all of a sudden. So now that they're on drug or placebo and all of a sudden making the changes in their life that they need to make and spontaneously see improvement. So that's actually a pretty good separation right there. Exactly.
And then also importantly, the very important statistic for all of these trials is HbA1c. So 30% of the people in the high dose arm were at under 5.7% on their HbA1c, which is pretty much a non-diabetic level.
That's great.
Yeah, so it's really good. I mean, there is, of course, a catch, like there is with all of them, which is about a quarter of the people in the high-dose arm did have to discontinue treatment because of adverse events, but they were all mostly gastrointestinal in nature. So there's like nausea, that kind of thing. So
isn't that the most common for GLP-1s?
Yeah, exactly. So what the investigators concluded was they probably just need to kind of change, since most of the people dropped out during the titration phase when they were just going up, that maybe they need to kind of make it smaller increments, just kind of a little bit softer and not as, maybe they made some drastic steps at some point that got people like, oh, I'm going to throw up. I got to get off this.
Yeah, well, I mean, you might lose weight and stop eating so much sugar if you constantly feel sick.
Well, that was the whole thing. That's what people were saying on the original GLP-1.
I know. I'm parroting that argument, but it doesn't seem to be true.
No, it's not true. And this was all dose-dependent, weight loss and everything else. So it's making all the signs are pointing the right way.
Yes. I've always liked this access for sort of treating diabetes. This GLP-1 it's a bit upstream of your sort of glucagon and insulin pathways, and it seems to be in some respects a master regulator of those guys. So it's sort of part of the feedback loop, as it always is. And this is also where a lot of the sort of genetic causes of insulin insensitivity seem to be centered on this little GLP-1 axis, right? So I've always been very like, if you have a mutation in a gene for like your GLP-1 receptor and it causes these insulin problems, maybe that's something good to drug, right? So I've always liked it.
Great, yeah, and it looks like it's just they keep working on it, improving it, in terms of the drugs that are targeting it. the Novo data was really great for their oral version, and the sub-Q data, which includes that the GIP receptor. So here we go. A glucose-dependent insulinotropic polypeptide.
Good. Awesome. Cool.
So that was some really nice news.
We like to see progress. And diabetes is like, I mean, I might just be making this up right now. The number one cause of morbidity. Was that accurate?
It's probably related to it, like because it's related to heart disease.
Yeah,
it's related to all these other things.
So many problems.
It's like the it's kind of like that whole metabolic area is the cause of so many problems, just across diseases. So no, if we can get this sorted, then that would be really great news.
Yeah. Cool.
Yeah. And some people were thinking this might mean that, hey, maybe the NASH market will be smaller.
Yeah. Well, how big is the NASH market anyway? It's like 30% of America if you see people quoted.
It's infinite.
Yeah, it approaches infinity because the statistics surrounding NASH are just stupid. Like they just sort of estimate that 30% of people have NASH. And my big problem with this is that if 30% of people have NASH, then NASH doesn't cause that many problems because 30% of people are not that freaking sick.
Yeah, they don't even know they have NASH because
they have no idea.
Yeah, it has no symptoms.
Is this something that we need to treat? No, yada yada yada. Yes. There's some stuff in there with NASH, and there is a mortality risk with NASH. It will elevate liver cancer, the 5th most likely cancer cause of death, to the 3rd.
Look, it's the Hallmark holiday of diseases. Okay, it's like. It's made up. No one really knows they have it.
It is not made up. You'll upset a lot of people by saying that, Max.
It's made up.
It is a clinical diagnosis.
Fibromyalgia has more going for it than NASH.
Increased fat and stuff, fibrosis in your liver. So,
well, yeah. Okay, look. There are people who have NASH that needs to be treated. But yeah, all these numbers that are pointing to 30 million people have it. That's just BS, and it's not going to happen. These insurance companies won't approve it for that many people. Never.
They're not going to approve it for freaking anyone, I don't think.
Well, first
they're going to have to just come out and say, "Oh, this is really, really going to, increase risk, and having this drug is really, really going to fix things." And that's just not going to happen. Cure diabetes first, because diabetes causes NASH. We know that. And it causes all your organs to fail, pretty much. And when it causes your liver to fail, that's NASH. That's basically it.
So basically, that company Oramed had, they had a good idea when they're trying their oral insulin to treat NASH.
No, that's a horrible idea, Max.
I know it's a horrible idea. I mean, first of all, oral insulin itself is generally a horrible idea.
It's a horrible idea.
And then to have oral insulin to treat NASH patients is doubly horrible. I mean, this company, it's like, I think Adam Fierstein had some joke like, well, why don't they also, mix their oral insulin with CBD and then treat NASH patients via the blockchain? Mm-hmm. Let's just put as many things in here as possible.
Yeah. I mean, the whole idea, the short story is insulin's a protein. When you eat proteins, you digest them like steak. They go away. So you have to find a way around that. And if they've found a way around that, I think there's just 100 other things that would be better targets than frickin' insulin. You've heard us talk about Mankind on here, and they basically came up with inhalable insulin, and it's just been a complete flop. So oral insulin, same story. It's a horrible idea. But if they could get a way for you to absorb a protein in a pill, that'd be neat.
Well, no,
but they don't. They don't have that either.
No, well, I think that you will absorb at least a little bit of it.
Well, they give you an enormous dose.
Yes, exactly.
And then they give you I believe it's like a permeabilizer, something that basically pokes holes in your gut, because otherwise the protein ain't going to get in there. So that's a great idea.
Yeah, no, it's a horrible idea. I mean, if anyone knows anything about diabetics and how they manage their diabetes, it's actually quite an exact science. Like if you're doing it properly, you're taking into account a lot and there's like a whole formula on how much insulin you need to take. And so you can't just take a pill that gives you some random amount.
Yeah. So what's the gastric retention time, of this pill, and like how fast this is going to be absorbed, and the food effect is going to be absolutely enormous. So,
And depending what you eat,
Exactly.
also. So it's a very bad idea. It's just funny how like these bioturds just keep.
But it's
coming
something
up
that
with
you
these-
could talk to stupid investors and be like, "This is so revolutionary."
No, if this works, it will be huge.
Yeah, that's
But it
the
won't.
one.
It won't work at all.
And it won't. This one wouldn't even be huge if it did work.
Well, you can make it huge in like analyst models.
You could.
Then there's reality, but you worry about that after FDA approval.
Yeah, you could just say, "Oh, look, this is how much insulin is out there, and if we could just charge $50,000 a year for all the insulin, it would be worth trillions of dollars.
I don't
We're
know.
the first trillionaires."
Insulin's pretty expensive already.
Insulin is expensive already.
Yeah.
How much is a dose of insulin?
I don't even know, but like it's not.
I know some
nothing.
cat just died because he couldn't afford like $600 dose of insulin.
Why would a cat pay
Not
money?
a cat, some dude. I'm just using the vernacular.
From the 50s?
Yeah,
Are
daddy-o.
what are you like? You're not even a hipster. You're a beatnik.
Stay cool. Stay cool.
Okay. Anyway.
Anyway, what's the next thing on the docket?
So there was also some interesting data that was presented at I think the IACH conference from MD Anderson. They had a CAR NK data set. So it's just like something similar to a CAR T.
All right, let me give a little bit of background for
Okay.
the
Do you want the data?
listeners. No, I don't need the data. I ain't got an idea what the data is. But a CAR NK is just using an NK cell as a natural killer cell instead of a CAR T cell. So the difference between a natural killer cell or an NK cell is they're pretty much what is responsible for some of your innate immunity. They don't actually become sensitized to the new threats that enter your body. They're already born sensitized to certain things. So they already know how to clean up certain bacteria the way they are. And they also respond to antibodies being stuck to things. So if they find some bacteria decorated in antibodies, they'll just go and kill it. The point here is that they are a different cytotoxic cell, right? There's two cytotoxic cells. One are killer T cells, the other one is natural killer cells. That's it. And so for some reasons that I don't think we have the space to get into here, some people think these NK cells might be better than T cells for some of this CAR T stuff. Some of this most recent data is using allogeneic CAR NK cells. So these ones are cells that have been grown up in a lab, frozen, and so you just can go into the clinic, be like, "Yo, I got leukemia," and they'll give you some of these there. Boom. You don't have to ship off your cells to Novartis or Gilead or whomever. Have them prep them for you.
Yeah, I mean, that's the whole problem with the CAR T. It requires like this huge process because every CAR T therapy is individualized to the patient. So it's the exact opposite of the whole idea of mass production. It's individual production. So it goes against the whole wealth of nations industrial revolution. So it's incredibly expensive. And off-the-shelf therapy would just be much more cost-effective.
Much more cost-effective and faster and easier. And a big problem with CAR T is that generally these people they got refractory disease, they're pretty sick, they already have a bad disease to start off with, and they're like, all right, well, this will take a month, right? Let's try to get, and I know some of them say they can get down to 2 weeks or something like that now, but the turnaround is not great, and these patients don't have a lot of time. And sometimes by the time they get the therapy, it's too late for them in one way, shape, or form.
And I remember Novartis had like a tough time actually making the cells. Like I think they had a relatively high failure rate, like maybe like 20%. Mm-hmm. So yeah, you'll wait all that time, and in the end, hey, they're not viable.
They can give it another shot. But a lot of times, and this is a problem I think people were worried about in some of these clinical trials for CAR Ts, where people would get enrolled and they would start to make these cells for them, and then they would progress before they got the cells. So it made the data worse than it could have been otherwise. Yes. Although it was still pretty good. That's facts.
So off-the-shelf therapy would definitely be a positive, which is probably why Allogene, which is being brought by Ari Beldergren from Kite, he just finished his Series A, $300 million in April. And he's already filed for an IPO, and fully diluted, it will be a $2.3 billion company 6 months after the Series A. But the funny thing is it's been what, less than a year since he sold Kite to Gilead, or around there. And with Allogene, he's basically proved that there's really no huge barriers to entry. You'll have a lot of competition. I mean, he was able to form a company and possibly make it public within like a year of selling it to Gilead.
Mm-hmm. I mean, the barrier to entry here is it's more like a non-pharmaceutical product, right? A non-biotech product. It's manufacturing, right? It's like the ability to make this and do this processing we're talking about is like literally the only barrier to entry. I mean, yes, you can have your little proprietary vectors that you're using to put these genes into the CAR Ts, but you know what? There's enough of those out there that anyone can make one, and they can tweak little bits of it, put the things on there in a different order, that sort of thing, and get around this crap. Because literally everyone and their cousin seems to have a CAR T nowadays.
Exactly. Like, I mean, obviously it's not easy to make. I mean, these are like, a lot of scientific expertise, but there isn't like the usual IP barrier, which makes it so like only a couple people can do it. Mm-hmm. And I mean, you see all that CAR NK data from MD Anderson. I mean, it was great. They had a bunch of CRs, and they didn't have the usual CRS, cytokine release syndrome, or neurotoxicity of CAR T. Yeah. So, what exactly is the investment proposition for these CAR T companies? I mean, you'll spend money on these clinical trials. Yeah, you might actually cure patients, but then there'll be 10 other CAR T choices out there. Some of them might be more convenient. So, and it's not like we have 2 approved products right now, from Novartis and from Gilead/Kite, and they're not really selling that much. They're selling, but like not. It's not.
It speaks to the whole
burning.
The whole idea is kind of this is the first time that it's a therapy that is a product. It's not really like a drug, and it's you're paying somebody to process these cells for you. It's essentially what it is. It's essentially a therapy, and that doesn't really fit into the sort of the same model as like a drug or a monoclonal antibody or anything else like that. There's no barriers to entry, and really it probably shouldn't be set up like this with these big drug companies running these things. It's probably something that there should be like CAR T clinics, right? And so you go to the CAR T clinic and they make your cells right there, and then they inject them into you. And I know, for instance, that's the way that Fosun in China is doing it this way. They're actually using the sort of footprint of clinics in China as where they're going to be doing CAR T. And they have a collaboration with Gilead Kite right now. So they license their CAR T, and they're going to use it just on like a clinic basis in China because they feel like it can get to people better in that way.
Yeah, probably. Yeah, it's a process. It's not like a drug. Mm-hmm. Although, when they make it allogeneic, then it will be more like a drug. But then again, there'll be the competition issue and all that other stuff.
Yeah, your IP is a lot better for an allogeneic. A lot better.
Well, but I mean, you'll have to have your own process. But I mean, everyone's going to have a CD19 CAR T, so it's not like you have the target nailed down. There's going to be a million to choose from.
But if you have an allogeneic one of these guys, then you can have pretty protective composition of matter surrounding that cell line.
Yeah, and then someone comes out with like, oh, I have a CAR NK, which works just as good, or like I have this dual targeting, blah, 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 or blah, blah, blah. I'm not sure about the actual likelihood of you profiting, especially if you're buying like Allogene at $2.3 billion, unless you're just going by the greater fool theory, which has worked for quite a while.
Worked. Yeah, it has worked.
No, it definitely it works until it doesn't. Mm-hmm. And then you become a bag holder and get made fun of. Mm-hmm. Well, on some other news, so CBD has been rescheduled. Thanks to GW Pharma, they got Epidiolex approved for epilepsy. So it's been rescheduled. Instead of Schedule 1, which means no medicinal use, this is forbidden, verboten, don't you dare. It's now Schedule 5, which I wasn't really aware there was a Schedule 5. And if you look on like the DEA website, it just means it's less abuse potential than Schedule 4. Which is like, oh, thank you. That really nails it down for me. But anyway, so it's a really good sign about the willingness of the authorities to kind of loosen some of the reins on some of these medicinal drugs that also have like at least some abuse potential.
You really like talking about drugs, don't you, Max?
Well, I cover a few cannabinoid companies, and I do believe that the government shouldn't be able to tell you which plant or whatever you can ingest of your own free will. I mean, I think that's a little fascist. So anyway, so I am a big proponent of decriminalization of these items, tax them like tobacco, let people use them if they want. They're much less dangerous than alcohol. There was a study that was just published in the Journal of Neuropharmacology, which actually did a whole. It was focused on psilocybin and was really calling for the rescheduling of psilocybin, which is the active ingredient in magic mushrooms. Because right now it's also Schedule 1, no medicinal purposes, but that's actually not really true because there have been multiple studies in end-life cancer patients and depression and substance abuse, etc., that there is some medicinal purpose in a therapeutic setting. So anyway, in this study...
And that's how they originally looked at LSD, right?
Yes, exactly. It was being used by therapists for a variety of different issues. And like for people with substance abuse, it was a great way for them to kind of reset their mind. So they're like, oh, wait, why am I drinking so much? Or why do I feel like I need these cigarettes? Like,
feel connected with the universe, and then you're like, I don't want to hurt the universe.
No, I don't think
I
it's
don't
about
want to hurt the world by drinking too much.
Well, one person was like, well, I realized that the most important thing in life is breath, because if you don't breathe, you die. So I probably shouldn't be smoking.
Wise.
It is. I mean, it just takes you to that simple lessons. But they have a great table in here on normalized ratings of harm potential for a variety of different substances. The worst one, of course, being alcohol, as it being a high rating for harm to both the user and to others, which is true.
Mm-hmm. I'm curious about this. So alcohol is the worst. What's the second worst? Meth?
Heroin.
Heroin. Okay.
Yeah.
Fair.
No, this is all like legitimate.
Fair.
So it's like alcohol, heroin, crack cocaine, methamphetamine. Although for methamphetamine, unlike with alcohol and heroin, where there's kind of like a equal harm to users, harm to others, meth is more like harm to users.
That's interesting. No,
Yeah.
I don't know any meth heads, but my impression was that they couldn't be trusted. And so I'm actually surprised that they're not hurting other people as much as they're hurting themselves.
Oh, I mean, have you seen those pictures, like the before and after? They're pretty gosh darn
Yes,
scary.
that's just government propaganda.
No, it's not. That's what they look like.
I can put whatever I want to my body.
Well, yes, you can, but if you know that that's what you're going to end up looking like, go ahead, man. But anyway, moving on. But according to this, benzodiazepines are kind of in the middle of the scale between GHB, which is the date rape drug, and ketamine. But LSD, mushrooms, they're like really all at the other end. There's really no risk for harm to others. And there have been those rat studies they've done with like cocaine or with heroin. If they want more, they push this little bar and they end up pushing it so much they die.
Mm-hmm.
They don't have that with these with like mushrooms.
Yeah, this. Would you imagine being a rat in a cage and then dropping acid? That's a horrible idea. That is a horrible idea.
Well,
that rat is like, my life sucks. This is awful.
Yeah, I don't know what a rat on acid would actually. I don't know
Probably
enough
hide
about
in
rat
a corner.
brains.
You probably come in there with your hands and be like, "Whoa, get away from me!"
Well, I bet if you dosed a squirrel, you wouldn't be able to tell the difference, because they're always kind of like tripping.
Well, they're always like act like they're on crack. That's for sure. They gotta give them nuts. Give me that nut. Give me that nut.
Okay. No, but I'm serious. It's like users will be like, okay, I'm done. I don't need to do this every day. If I do this every day, it's just too much, because I mean, a lot of people have spiritual experiences on it. You don't want to do that. It's a very intensive kind of thing to do.
Well, my problem with this is that it looks like this is one of our great ideas for good old Pyramid Biosciences, the company we're going to start. But Peter Thiel beat us to it. He's starting a magic mushroom company. So I think we've got to double down, Max, and start an acid company. We're just going to have acid for weight loss or something like that.
No. Acid for we can do the same thing he's doing with like depression.
You can't eat while you're tripping. You can't eat while you're tripping. You put like the meat on the fork and you're like, ugh, what is this stuff?
Well, no,
I can't put this into my body.
No, you can do it for addiction. So I mean, if you're
but that's
doing
not a good market.
It is if it works.
I mean, we're going to give heroin addicts acid to get them off of heroin.
Yeah, no,
that might work.
The guy who started AA started it after he did belladonna, and he had like this whole spiritual experience thing, and that's how like AA started. No, but these people kind of it's almost like electroshock therapy, kind of like a similar idea. Like it sort of zaps you, resets your mind. So because a lot of addicts, they get into this groove. Mm-hmm. And they just keep doing it because it's easy, because that's the way their brain's been working. And this way it sort of smooths it out a little bit so they can do other pathways, think a little differently. And there have been some really good results in relatively small studies on addiction and stuff. And interestingly, both the FDA and EMA, when they were approached by different groups, and I think one of them was probably Compass Pathways, which is Peter Thiel's company, mm-hmm. So they wanted to do a study in like end-stage cancer patients and just work on their depression, because there was already been data that it works wonderfully in like terminal patients. Of course, the regulators were like, it's not a DSMB category, so I don't think you can go for that. No one's going to pay for it. No, seriously. So they're like, well, why don't you go for kind of like the bigger fish, which is depression? So the regulators are actually behind this. They don't have a problem with it, because the way they're doing it, they're not talking about like giving it at the CVS to people and then they could just go trip. It would be in a therapist's office, with someone kind of talking you through it, because that really limits the downside, which is that, maybe you'll do some self-harm because you'll try to cross the street and you won't see a car. You think you're in a field.
Oh, they always used to say people would like jump out a window because they thought they could fly or some stuff, which I'm pretty sure is government propaganda.
No, a lot of that stuff was government propaganda. But no, I mean, stuff like that can happen. But if it's like supervised by a professional and it's like in a calm environment, the risk of a bad trip are really very low, and you can actually get a lot from it. Apparently, like the higher the dose, the better for a lot of these things, because the more spiritual the experience, apparently. But like you would have to have supervision for that, because like otherwise, yeah, you might think you're in a forest, but you're in the middle of Manhattan or something.
Okay. All right. So I think I'm officially adding drug talk to the list of banned topics, Max. I hope you got it out of your system.
Okay, biotech is drugs.
Biotech is drugs, but you know what I talk about when I talk about drugs.
No, what are you talking about exactly? We're talking about therapeutic
illegal
uses.
Drugs.
Well, technically, anything unapproved by the FDA is illegal.
That's not true. It's just not marketable.
Okay.
I'm going to go to the store and I'm going to buy paint thinner and I'm going to smoke that shit. I can do that because I'm an American.
Okay. And you can't just go out and, buy some of these things too.
The government said I can put paint thinner in my body, but I can't put methamphetamine in my body.
Look, they basically made alcohol a Schedule 1 drug at one point. So, I don't really care what the government thinks.
They're going to come after you. You realize that. They're going to hear this podcast. Big
oh, yeah, I'm sure they really care.
And they'll come after us. All right, what else you got, Max?
Yeah, this was interesting. So there was a Bloomberg article about this doctor who was... he was caught for getting reimbursement for surgeries he didn't do.
Okay.
And I think he also botched some surgeries because there's patients suing him. So it's a guy I think it was in Brooklyn or something.
I'm not surprised.
Yeah, something
what part of Brooklyn? Do you have any idea?
No, I don't know.
I'm just curious.
I'd have to see it. But
okay.
So, he obviously couldn't practice because of all of this. So instead he got this side job doing insurance appeal reviews.
Oh.
And he made hundreds of thousands of dollars doing this when he's basically some quack who, he botched a bunch of surgeries, made a bunch of stuff up, and he was able to do it because there weren't the checks and balances in the insurance system to make sure that, hey, the people reviewing the appeals actually know what they're talking about.
Mm-hmm.
I think he used a friend's credentials or something.
Oh, I'm going through this right now because my wife is pregnant, and I'm gonna dip out on this podcast here like any day now and go help raise my child. But in the meantime, I have been having to deal with insurance companies like crazy, and they are a freaking nightmare. And we've had to get so many freaking appeals for different stuff.
Like what?
And at one point, they actually said, "Oh, we found somebody else that can take care of you. It offers these same services." They're in Nyack, and we're like, "What? We're New Yorkers. We don't have like a freaking car. We're not going to be like, even if we did, we're not going to go to travel to Nyack to go see a doctor when we live in Queens. It doesn't make any freaking sense." And luckily, this person was 31 miles away, and they can ask you to travel up to 30 miles. So they probably were like, oh, they're in this zip code, and they just chose the wrong side of the zip code and chose somebody within 30 miles for like our zip code, but we were a little bit over the line.
Maybe it works differently, like in the city versus the suburbs. So I have 3 kids, and they all were born in the same hospital in the suburbs. And maybe it's like, because there aren't so many choices, they're like, yeah, okay, whatever hospital they want if it's close. That's how they work.
Well, long story short, they're paying for it.
Yeah, after a lot of work.
It's because
my God,
there's
there's
no midwife practices in New York. There's like 2.
Yeah, there's a reason. People want doctors.
Well, not everyone.
Well, non-hipster people.
Yeah, okay. Anyway, what was the point that we were making? What were we talking about? Insurance?
No, we were talking about this doctor who was doing fraudulent surgeries and then ended up reviewing insurance appeals.
So I actually, when I was thinking about this, evidently in like the Sheepshead Bay region of New York, and I don't know why it's out there, there are these like massage and chiropractic clinics that are enormous insurance scams. Like if you look at like the rate, like 'cause I saw this once on a map of like Medicare claims, and there's like a dude in Sheepshead Bay that claimed something like $6 million in 2016.
Oh, he's a Russian Jew.
I have no idea.
He must be.
I wouldn't necessarily jump to that conclusion.
Well, I'm a Russian Jew, so I can do that. I'm not like dissing someone else, but like no, that's like what a lot of Russians in the kind of like that Brighton Beach area are known for, like doing these like Medicare scams. Because look, if you grew up in the Soviet,
there's tons of them around there. Like I looked at this map because there's this one dude that popped up, and I was like, "Whoa, this is crazy." You look at all these other ones, and they're like small beans compared to this guy. He was pushing the envelope. They were like, $500,000 in claims, $600,000 in claims, like really typical.
Well, Russians,
for massage.
If you want to do it real. Like, go for it, man. I mean, look, this is the issue. It's not like some genetic thing. It's like if you grew up in the Soviet Union or or something close to it, you have to get by ripping off the government. So then they move here and they continue to do it, even though it's a completely different system, and you can get by without ripping off the government. And so you end up with like these kinds of clusters.
So anyway, tell me, what's the story with this guy?
No, so he got caught. He made like hundreds of thousands of dollars, and like people were appealing like stuff that they really needed, and he would just say no, they don't need it. And so some people who he had rejected are now getting the treatment that they need. But like there was just no, the reviewers of these appeals could be complete and utter frauds, and you don't even know, and the insurance companies don't know. That was an interesting story.
Everyone is screwing everyone. There's doctors screwing insurance companies, and screwing insurance beneficiaries, who are being screwed by doctors, who are being screwed by drug companies, who are screwing people on clinical trials, and they're screwing more doctors, and then we're all screwing each other.
Oh, screwing.
It's a big clusterfuck.
Is this like an HBO show?
Screwing on HBO. I'm pretty sure the name of that show is The Deuce.
No. We didn't talk about Omeros, did we?
We didn't talk about Omeros.
Oh yeah, I wanted to talk about Omeros. So Omeros, which is just a ludicrous company. So they just issued a press release on their data for OMS 721 in IgA nephropathy.
Awesome.
So this data, first of all, their press releases always have the smallest font and they have the most text.
Yes.
So, I mean, I swear they must have like 2,000 words in here.
This is like the reverse of what you did in college with your essays to try and make them look a little bit longer and fill up like 5 pages. They do the opposite, where they want to fit in so many goddamn words that you're going to miss the fact that their trial failed somehow.
Yeah, so in about 1,000 words down, they had, for the 9 evaluable patients, median reductions in proteinuria were 18.4% and 18% in the treatment and placebo groups, respectively.
So 18.4 versus 18. It does nothing.
No, it does nothing. And then they had this extension study, right after it, and they show a lot greater reduction from baseline, but they don't have a placebo arm because everyone just went on drug.
Mm-hmm.
And the company has said that, the lead-in phase was just meant really to test for safety, and the patients weren't trained on compliance. They said this at one of the conferences right after this.
Well, maybe
data.
you fucked that up now, didn't you? Maybe you should have trained the patients on compliance.
It's an IV. I mean, I don't know what they need to do here.
So what you're saying is you messed up the trial. So instead of blaming the drug, we should blame you. So what you're saying?
But
Well, let's blame Omeros regardless. I can't stand this company. I mean, first off, this drug 721 targets lectins. All right, lectins are like some of the most numerous proteins in your body, right? And they have a number of different functions. They do various maintenance things. You'll actually see lectin in various like protein shakes and stuff like that because they got it from soybean or something like that. It binds sugars up, and our lectins do a few more complex things than that. But this is not a major pathway for modulating the immune system. They've been investigating this thing for some of these hemolytic disorders, like Solaris is approved for, right? For aHUS.
Yes.
And now they went after IgA nephropathy. Just because something, these targeting these lectins was their pathway. It's complete garbage.
Yeah, I mean, they only had like 9 patients in this study. I mean, I don't think any doctor's really excited about this.
They'll never come out with data on that aHUS study either because, number one, there's an effective drug for aHUS.
Yes.
It's Solaris. And there's only something like 20 people with aHUS in the country.
It is very small. I don't think it's that small, but it's small.
Yeah, it's really small. And so they're not going to leave their drug to be able to go on and try this other drug ever. So it's going to be running forever.
Oh, yeah. No, and they like it that way.
Mm-hmm. And not to mention their main drug is just 2 commonly available medications mixed together that you put in somebody's eye. Although they did just announce that I believe through legislation they kept their pass-through status.
For 2 years.
For 2 years. And they've been keeping that going longer than I imagined. But one day it's going to run out.
Well, bribing politicians has been, it's a time-tested method of...
It's a viable strategy, they might say.
It is, yeah. But no, Omeros is it's an interesting company. So last year, someone named Art Doyle, that's a nom de guerre of a short, who put together a report on Omeros. It's actually really funny. So he has this whole like Omeros by the numbers table. So number of years it has been since Omeros has claimed that MASP-2 is a phase 3 program, 1.25. Number of phase 3 clinical trials Omeros actually has ongoing for products in development including MASP-2, 0. Number of patients the company has actually treated in its phase 2 program in 4 years of development, 13. And it just goes on and on and on. And like number of times management has implied that OMS 721 is a subcutaneous program, currently infinite. And the number of patients in the OMS 721 phase 2 trials that have been treated subcutaneously, 0. Yeah, so they do a lot of misdirection. They don't have like the usual kind of healthcare specialists as investors. They have like some family office out in San Francisco, which owns like 10 or 15% of the company, and they're not really healthcare people. So.
Not to mention, if you look at so people will talk about Omidria and people will talk about 721. But if you look at their pipeline chart, they've got like a whole bunch of other stuff that they say that they're working on, maybe, but I've never seen anything about anything else on their pipeline, ever.
Yeah, no.
And there's easily 10 other things.
Art Doyle actually has a nice slide in his report, just comparing the Omeros pipeline from April 2015 to June of 2017, and it's just remarkably similar. Like there's no progress on anything, and one of their drugs that they include in their pipeline is actually not even their drug; it's just some commonly available generic. They don't really have rights to it. They theoretically are running a trial on it, but
you can run a trial on a generic that you don't own any rights to.
No, I know, but it's like they're not actually running anything for it. It's just like a PowerPoint thing. It's literally a pipeline. Like we're working on it, okay, but you're not actually enrolling any trials. So yeah, no, they're an interesting company with a relatively high valuation.
Yeah, where are they at right now?
Right now, I don't remember, but like they've been hovering between like 500 million and $1 billion for a while. So, but it's hard. Like a lot of people are short it, and then you got like people who are like, "Oh, the shorts are evil. They're just trying to kill this wonderfully diversified company." Just like whatever, the usual.
All right.
And one more thing is just there was an article where these people came forward and they admitted to submitting journal entries to various journals just to see how ridiculous they can get and still get approval, acceptance. So
it's just like professional journal trolling.
Yeah, pretty much. And I mean, this isn't a new idea because like apparently 22 years ago, someone did it where they mixed post-structuralist gobbledygook with physics catchphrases. Yeah, they got published. It was literally gobbledygook. It was a joke. It was by this guy named Alan Sokol.
Yeah, this is a famous case, and you sort of learn this in academia. And people have some varying opinions about the Sokol case, because you can always find some sort of academic vanity press to publish whatever the hell you want.
Yeah.
Is that really an indictment of the sort of system of using the academic journals or something?
I mean, it does kind of highlight the whole vanity press thing. Like, okay, I mean, you might say like, oh, well, no, it's not vanity press. This is a legitimate article. And then, I mean, you're proving that like, no, it's pure vanity. Look at this. I got gobbledygook.
Yes, this is true. And the average person is not qualified to evaluate. Hell, I mean, I have a PhD and I'm not qualified to evaluate virtually any of the journals out there and whether they're a good journal or not. If I see something and it's just like, I don't know, European Journal of Cardiac Intervention, I don't know if that is a good journal or not. It sounds like a good name.
Well, if it doesn't
sounds
exist,
very official, but I don't know.
Yeah, we should start it if it doesn't exist.
Oh, yeah, we should.
Oh, that's a good name.
Yeah.
Yeah, we'll charge people $10,000 per submission or something.
Yeah,
let's do that.
Yeah, let's start a vanity press.
Anyway, so these people who were doing it, one of the things they did was they took like a chapter from Mein Kampf and then just kind of edited it from a feminist perspective and got it into some humanities related journal.
So are these guys making like a men's rights point?
No.
That sounds kind of men's rightsy.
Well,
that sounds a little men's rightsy, Max.
No, it's not men's rights.
I think we should be careful, talking about
first
men's rights douchebags.
Wait. So men don't have rights?
But men's rights, the men's rights movement is very douchey. It's very, very douchey.
They're not. No, they're not the men's rights. Well, first of all, the journal that published this whole expose is actually multi-spectrum. I don't know, like how do you like it? They have like libertarians, they have socialists, they have right, but it's basically free thinkers who think that like there's a certain newspeak way of doing things on academic journals. So if you conform to the collective, you'll get approved. So there has nothing to do with like men's rights movement or anything like that. It's just purely like, how ridiculous can we get it? Just based on reading other articles and whatever. Yeah.
I mean, my favorite one of these studies was this. I believe it was a group of graduate students in computer science. They saw some journal articles that they were like, we cannot understand this. This journal article is impossible to understand. And so they thought it would be funny to write a computer program that can make realistic sounding journal articles using, just like you were saying before, like a gobbledygook, putting together as many sort of buzz phrasey high complexity computer science topics as possible. And could they get it published? And they did. They got some published, and then they ended up having like a talk at a conference about one of these things, in which they sort of revealed this is what they did, right? And it was actually about this program that they wrote to do this and fool everyone.
That's great. I mean, that's almost like, just coming. We should do that with like a poster. CBD oil infused oral insulin for NASH in diabetic Alzheimer's patients.
We're maybe onto something. CBD, the solution for the connection between Alzheimer's and diabetes?
Why not?
Question mark? Because you can always put the question mark on there, and that removes any sort of culpability, because you're not making a claim. You're asking the question.
Yeah. So should we short Omeros?
Is Ted Cruz the Zodiac killer? I don't know. I'm just asking the question.
I have no way to disprove it. You can't prove a negative.
All right. Well, do we have anything else, Max?
Nah, that's it.
All right. Thanks, everyone.
Yeah.
Talk to you next week.
Bye.
Our theme music is by Hazar.